Hello, this is Claire Coles, professor at Emory University School of Medicine, and this is a talk on fetal alcohol spectrum disorders, implications for cognition and education. I'd like to acknowledge some of those who have supported our work: the National Institute on Alcoholism and Alcohol Abuse of the National Institutes on Health, a collaborative initiative on fetal alcohol spectrum disorders, or CFAS, the Centers for Disease Control and Prevention, CDC, as well as the Georgia Department of Behavioral Health and Developmental Disabilities. And I also want to state that I have no conflict of interest to report. There are a number of problems that have been observed in individuals who are diagnosed with fetal alcohol spectrum disorders. And these include motor problems, visual spatial deficits, several different kinds of cognitive deficits, specific academic problems, and problems with behavior, including arousal dysregulation. Finally, we observe long-term health problems in individuals who are alcohol affected. It is the damage to the central nervous system, or the brain, which is the basis for the cognitive effects that we see in fetal alcohol spectrum disorders. When we examine the brains of individuals who are prenatally exposed, we see a reduction in overall volume of the brain. We see malformations and reductions in the volume of gray and white matter. We often see thin or missing corpus callosum, which is the bundle of nerves that connects the two halves of the brain. And we see alterations in brain activation, or how much the brain responds to a stimulus. Finally, we see alterations in functional connectivity in the way in which the brain communicates with itself. This is a diagram showing structural differences in the brain of individuals who are alcohol affected. In the first column, A, we see the overall general effect of prenatal alcohol exposure, with those areas which are impacted shown in color. As you can tell from these illustrations, there are significant areas of impact on the brain in a number of different regions. As a result of these changes in the central nervous system, there are persistent global deficits, even when we account for the effects of social class and the postnatal environment. And it is, I believe, well illustrated by these fMRI and MRI slides, the reasons for the neurological basis for behavioral findings. In addition to the global deficits that we often see in these individuals, there are a number of specific areas of deficit, which I will explain. Therefore, when we are working with individuals with fetal alcohol spectrum disorders, we need to understand that there may be problems in a number of areas throughout their lives. These areas can include physical health and motor problems, behavior and social problems, problems with development and cognitive skills, and finally, academic and vocational problems. When we look at individuals who are alcohol affected, we often ask ourselves, is there a pattern of learning and behavior problems in fetal alcohol spectrum disorders? It can be hard to pick out in a specific individual. It can be hard to pick out this pattern against a complicated social background, or one in which there have been a number of medical problems. Still, certain patterns have emerged. We do see cognitive problems. These can be both global and specific. We see problems with behavior, and often these have to do with ability to self-regulate and to exercise effortful control in planning and organizing behavior appropriately. We often see early deficits in motor and visual motor skills. We see early and persistent deficits in executive functioning, or the ability to plan, organize, and think about what we're doing. And we commonly find secondary disabilities in academic achievement and later behavior, including mental health issues. There are problems common in FASD that affect school performance. Reading and spelling skills sometimes are observed, and, however, these are usually consistent with a person's overall ability level. So if a person has an IQ that's in the borderline range, they will typically have reading and spelling skills that are consistent with that range. Often there is a more significant deficit in math skills, and this seems to be something which is frequently observed in alcohol-affected individuals. We also often find that completion of school and appropriate training for vocational life may be negatively impacted by prenatal alcohol exposure. When children present to us in the clinic at school age, there are several different types of presentations. One group of children presents with intellectual disabilities. That is IQ from 50 to 69, and they may have significant physical findings. The little girl you see in this picture is one such child. Another group of children present with borderline IQ, and that is an IQ from 70 to 85. These children often present with a history of foster care, having left the custody of their biological parents. They may have specific learning deficits rather than a global deficit, and often they present with behavior problems, which may be attributable both to their prenatal exposure and their postnatal environments. A third group present with what we refer to as nonverbal learning disabilities. This is a split between their verbal and their nonverbal skills, with verbal skills being significantly higher than the so-called performance skills, which involve nonverbal or visual spatial performance. And finally, we see children with specific learning problems, and these are often centered around executive function skills and mathematics. In the first category of children who have problems with general learning ability, they frequently learn at a slower rate and are unable to master material that is presented to them very quickly. These children need more trials to learn a task, and they have to experience working with a concept to consolidate the skill. With children like this, it's important that they completely master a skill before moving on to the next level. Such children usually also need an active learning experience. They need to explore, experiment, talk about, and move around the materials they're working with in order to help them in the learning process. Such children often need what's called a multimodal approach to learning, in which they have visual experience, an auditory experience, and one that now allows them to manipulate materials. Another group of children may have problems with executive function. Individuals with fetal alcohol spectrum disorders often demonstrate difficulties with regulating their basic attention and arousal systems in order to focus appropriately on the task at hand. They may have difficulty in thinking about what they need to do in the future and in planning and organizing materials to accomplish that task. They may have difficulty in mentally manipulating information, so it may be hard for them to do problems in their head, for instance. They may have difficulty in changing their strategies when presented with a dilemma, or in thinking about things in more than one way. This is called cognitive flexibility. And often children who have this problem will persevere or continually try to do something in the wrong way without stepping back and thinking through the problem in order to determine whether there might be another solution. They may have difficulties with abstract reasoning. Concrete reasoning may be possible for them, but when they are raised to the next level and there's no actual concrete object, they may have more difficulty engaging in that kind of learning and thinking. A final issue is problems in generalizing or in applying knowledge they learn in one situation to a new situation. Executive functioning problems are often based on problems with organization and planning. And we know that children with FAS demonstrate problems in organizing and planning tasks. Here you see illustrated a Tower of London task. Another task that has demonstrated difficulties for this group is what's called a Wisconsin card sort, which is a measure of cognitive flexibility. These deficits in testing simply reflect the ongoing deficits in the real-world experience, which are very similar. These deficits may also indirectly impair memory function. One area that we know is very commonly impacted is working memory. When we think about working memory, there are potential problems in a number of areas. One might be auditory or visual processing. That is, how we understand an auditory signal or how we understand a visual symbol. Another might be in the short-term memory, or how long you can remember something. Another may be in whether or not something is in your long-term memory or in retrieving something from your long-term memory. And finally, once you've been able to do those things, how well can you manipulate information in your memory? By example, and using this little boy's dilemma as an example, let's say we say, solve this problem in your head. 17 minus 9 equals. In order to do this, you have to hold in your working memory the instruction I just gave you, and then the specifics of the problem, the numbers, the minus, and the equals. That's 4 different things, 5 different things, including the instruction. From long-term memory, you have to remember what these numbers mean, that 17 is bigger than 9, for instance, and what subtraction is, and how to do it. If you can remember all that, you then have to correctly manipulate the numbers to get the answer. So what seems like a very simple little problem becomes very complicated for the person who has a deficit in some of these areas. Another area in which we see significant issues in this group of children is in visual motor and graphomotor skills. Here in this illustration, you see number writing by one of the children we worked with, who had had 2 years of schooling, formal schooling already, and was still unable to correctly write his numbers. This can have a huge impact on math, of course. And this is because math is an area in which understanding spatial relationships is very important, and which you have to understand the size, quantity, magnitude, and intensity of various features of symbols and objects that you see. You have to be able to recognize and understand the symbols of mathematical operations. And you have to have the ability to line up columns to do advanced addition, subtraction, and multiplication. In terms of graphomotor skills, being unable to write effectively can interfere with school performance. People who have problems with fine motor skills and graphomotor skills often are fatigued by writing. Their writing may be hard to read, sloppy, or messy. They may demonstrate poor organization on a given page or line. Their letters or numbers can be scrunched together, crowded, and if you're talking about mathematics, the numbers, if they're not neatly written on normal lined paper, may be impossible to interpret. Another area in which we find difficulties presenting themselves is attentional regulation. Early on, it's important to be able to control your arousal in a physiological sense, because if you cannot do so, it's impossible to focus your attention on the information that you need to learn. So to the extent that your arousal interferes with your attention, your learning will be impaired. We see that attentional regulation is impaired in middle childhood and adolescence among those with FASD. We also find that this impairment, while similar to ADHD or attention deficit hyperactivity disorder, is not exactly the same. Having all these problems, there are a number of cognitive, developmental, and social service needs of children exposed to alcohol. And we have identified the following in our clinic. Behavior regulation problems are frequent, and these usually require support from parents through parent training. The children may need specific cognitive habilitation or remediation. They may need therapy to address behavioral issues, or eventually they may need psychiatric care if these other skills are not able to remediate their problems. They may have learning problems. They require psychoeducational assessment, assistance from educators in designing appropriate programs. They may need individual speech therapy or occupational therapy. They may need tutoring services to support their learning. The parent may need training to help in their partnering with the school, and the child may need special education services. Other areas they may need support with are social work services and assistance in order to link families with community resources. And eventually, children may need vocational planning and support in developing skills that can be used for work in the future. When we think about things that have been successful in intervening with individuals for FAS, we find from the literature that early diagnosis and treatment are very helpful, that each child must be thought of as an individual because alcohol may occur during any point in pregnancy and may have different effects on different people. We have to regard each child as an individual. It's not a one-size-fits-all phenomenon frequently. We need to educate the parents and caregivers about the FASD disorder and the fact that it is based on a brain problem rather than a behavior problem, that the child is doing the best that the child can in the situation, but they have problems due to the impact of the alcohol on the central nervous system. We need to educate teachers in the same way so that they understand the disorder, the reasons for it, and what its characteristic outcomes are. We need to help children learn to control their arousal level, in other words, to develop self-regulation. We find that behavioral learning methods are very effective working with both parents and teachers, and finally with children. And we find that using specific skill-building methods are highly effective in helping children learn. When we come to planning the intervention should begin with a comprehensive assessment of the child's strengths and weaknesses. We need to know the global ability of the child. We need to know their social context and what social resources are available for the child. We need to know if there are any health issues, including vision and hearing, and other physical issues which might interfere with learning. We need to know the current resources which can be brought to the task of helping this child. We need to build on their specific strengths and weaknesses, and we need to know their educational history. When we know those things, we can take the next step in planning the intervention based on the child's individual needs. And to do so, we need to involve our educators and the family caregivers to support the educational activities. Finally, having taken these steps, we need to monitor the progress of the learning intervention and determine its results and reevaluate as necessary. When we look at those interventions which have worked with alcohol-affected children, we find that existing methods that we already know and understand can be adapted to the special needs of children with fetal alcohol spectrum disorders. and that these interventions and treatments can be provided within existing networks, school systems, and tutoring services, and so on. We typically find that caregiver involvement is very, very helpful. The parent may need to be a focus of intervention as well in order to have them support their child's learning and to help them understand what fetal alcohol spectrum disorder really is. We often need to help the parent by providing tools to support behavioral change. We have found that explicit instruction is the most effective method in working with children. Children learn new skills better with explicit, focused instruction. We also have found that error-free learning is very important for basic skills. That is, we don't let them learn things the wrong way first and then try to get them to change, because since the children have problems in shifting from one aspect of a situation to another because of this lack of cognitive flexibility, it's important that they learn things appropriately the first time. Thank you very much for your attention to this discussion, and I will be happy to answer any questions or listen to any comments you may have. I am also happy to correspond with you by email, and I have given my email at the bottom of this slide. Thank you.